We go. So the title she chose was A Palliative Approach to Care. And before we get started, I would just like to start with a land acknowledgement. This is a lake up in Algonquin Park. It's called Grand Lake, and that's my canoe, and I'm paddling through there in mid-September, and the foliage was beautiful. And the CHPCP resides at Briere, which is here in Ottawa. We want to acknowledge that we live and work on Indigenous land. The Briere is situated on the traditional unceded territory of the Algonquin Anishinaabe Nation. And with this recognition, we continue to reflect and move towards efforts to further reconciliation. Providing equitable access to healthcare services for all Canadians is a compelling social obligation that includes striving to ensure that there is accessible palliative care for all, including Indigenous people within the nation. So as we gather today across the region, I encourage you to acknowledge the origin of the land that you live and that you work on. And if you're not familiar with land acknowledgements, a great site is native-land.ca to explore and learn more about this process. You're taking a full hour, and I'm going to pack it as fast as I can, and you can stop me anytime. I like an engagement with people, so there is a chat, and Carl's going to manage the chat for me. And so if you want to put something in the chat, Carl will bring it up as we go. But I'd like to start at just a time of reflection, talking about palliation, about living, about dying. We all have our own stories of our own lives, both working and personal. So today I have a little candle that's on my printer behind me. I think you can see it. I've lit a candle as a time to remember and to just be present and have a focus while we talk and discuss these topics. And probably some of you have seen the stop sign. I know during the pandemic, we all had stop signs in our institutions. Before we got into the door, there were these big red stop signs telling us what to do with regards to COVID. And it reminded me of the acronym STOP. Stop, take a breath, observe what you're thinking and what you're feeling, and then take a moment, just a quiet, sacred moment, and proceed mindfully. This is a great practice that I use when I'm working with residents and patients in all different types of settings to just help me become a little more present and a little more mindful. So I'm going to encourage us to take 30 seconds to just stop, notice your breath, observe whatever you're thinking and feeling, and then try to just flush those feelings and have a 30-second pause. And then we'll go from there. So if this is new to you, give it a try. And if it's a part of your practice, here's 30 seconds. So here we go. Take a breath. Notice those thoughts, any feelings that you're having, and just kind of let them flow by. Say, oh, there's a thought, there's a feeling. And with each breath, try to quiet your mind. Breathing in and breathing out. Breathing in again. Within the pause, focus on your breath. Breathing in, breathing out, and breathing in again. And take the last breath of this pause moment as we move forward. Maybe put a smile on your face. Let's journey on. Thank you for doing that. So I have 3 objectives today. I want to talk about what is palliative care and why is it important. I'm going to talk about 5 key components of palliative care, and then how and where to access palliative. So I'm interested in who you are. We're a small group, so that is wonderful. And if you just want to put in the chat, and Carl will let me know, but kind of who you are and where do you work and why you're here. If you're just coming for 1 hour, why are you here? And then Carl can read that out, and that will help me as we move forward. I also would love to know what words come to your mind when you hear the word palliative. If you want to give me a few words, I'd be happy to hear that too. Just take a little moment to write in the chat, introducing yourself. Maybe other people don't know you are either, or maybe you all know each other. And then give me a few words. If you had to create a definition, or when you hear the word palliative care, what comes to your mind?
Okay, so we have Keely from Congregate West who says they're joining to learn more about everything palliative.
Great.
And Tammy from Congregate Care. Also, we have Nicola, the Regional Manager of Health and Wellness for Rivera, who's thanking for having us. And palliative care, they say, equals giving the best holistic care possible to improve sorry, there was another chat over it.
Yeah.
Best holistic care possible to improve quality and quantity of life left.
Yeah.
And another person works with home and community care
Journey.
support services, and palliative means help.
And I see someone said a journey, end of life journey, receiving support, emotional and physical.
And another person says that palliative to them means, or that's the one you just read, sorry.
Support, eh, Carl? Support. Yeah.
Another person says palliative care is a passion of theirs, and there is acceptance of your end of life journey and receiving the support, emotional and physical, needed. Another person says palliative care means support. Another that a palliative team is equal to comfort, care, support with journey in their life towards end of life.
Well, Carl, as I read those, and thank you for putting some thoughts down in the chat. It helps me know who I'm talking to. As my husband would say, it sounds a little bit like maybe I'm preaching to the choir. It sounds like people have a little bit of a sense of what palliative care is. I hear support, I hear comfort, I hear team, with patients and families, living and dying. I'm hearing all those words. So hopefully this is a really good review for you and may give you some tools when you're trying to talk with other staff members or with residents and people that live within your environment. Thank you for doing that. Thanks, Carl, for reading those out for me. When the general public think about palliative care, and I often tell people that's my job. And I remember when I was a young palliative nurse years and years ago, I told somebody that I was a palliative care nurse working in an environment of community care in Southern Alberta. And a woman said to me, "Oh, I've heard about that. It's something to do with the roof of the mouth." And I said, "No, not really. The roof of your mouth is your palate, and dental hygienists and dentists work with the roof of your mouth, and I do offer mouth care, but the word palliative is not really related to the roof of the mouth." I think most people in the population, when I talk about palliative care, usually think about preparing for dying, preparing for death. And it is that, of course, but a palliative approach, as most of you I think are quite aware of, is much more than that. So the World Health Organization has given us a very concise definition that palliative care is an approach that improves quality of life for patients, adults and children, and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through early identification, correct assessment, and treatment of pain and other problems. It's interesting they use the word problems and other problems, whether physical, psychological, or spiritual. And that was just last year. When I look at that definition, I hear those words that I think are really important. Things like quality of life, life-threatening or life-serious or serious illness or life-changing illness, I sometimes hear. Relieving suffering, or at least attending to suffering. Some suffering, I really believe, is we cannot relieve, we can't eradicate, but we can attend to suffering and accompany people on that journey. Early, I see the word early, correct assessment and treatment of all symptoms, and from a holistic perspective. That's a lovely definition. I'm going to share with you a little video. For the show of hands, how many people have seen this little video? It's called An Introduction to Palliative Care. Oh, Miss Deb, you're going to love this video. It's a sweet little video, and I have showed it to so many families, and it's kind of gentle, and it helps people have a nice, gentle approach to what is palliative care. So here we go.
Introduction to Palliative Care. World Health Organization defines palliative care as an approach to improve quality of life of patients and their families facing problems associated with life-threatening illnesses through prevention and relief of suffering by means of early identification, assessment, and treatment of pain and other distressing problems, be it physical, psychosocial, and spiritual. While illness weakens the patient's foundations, palliative care offers a stronger layer of support system to help patients live as actively as possible until death. Anyone with life-threatening illnesses can receive palliative care. These include patients with advanced cancer, chronic organ failure such as kidney, heart and liver failure, frailty-related illness such as advanced dementia or Parkinson's disease. Palliative care is provided to patients at their homes, in nursing homes, hospices, specialist clinics, community hospitals, and acute hospitals. There are various ways to achieve these aims by using medication to treat pain and other symptoms, supporting patients and families in complex decision-making and advanced care planning, providing psychosocial support to help patients and families in coping with illness, as well as offering grief and bereavement support. A multidisciplinary team is essential to support patients and their loved ones. The team usually consists of doctors, nurses, social workers, therapists such as physiotherapists, occupational therapists, speech therapists, music and art therapists, dietitians, and psychologists. In conclusion, these are some general principles of palliative care. Palliative care affirms life and regards dying as a normal process. The intention of palliative care is neither to hasten nor postpone death. Quality of care is enhanced through management of symptoms such as pain, nausea and vomiting, delirium, and others. Palliative care uses a team approach to address the needs of patients and families.
I'm going to stop the video right there because I just love, there's a little statement of what is hospice palliative care. What is this approach all about? And we have the World Health Organization with their fancy definition, but sometimes just having something that's a little easier to be able to put into your vocabulary and to be able to use, that's a lovely little piece. And in sharing that video with families, they kind of go, oh, I didn't know it was about affirming life. I didn't know it was about seeing death as normal. It's not a catastrophic moment in my existence. It's about managing. It's about being accompanying with me. It's a team approach. It's a lovely little kind of capsule there to share with other people. There are many little videos like that. Pallium has a couple of videos too that are quite helpful in just using to share with people about what is a palliative approach. And if you're using a palliative approach within your residence with certain people that live there, being able to share small little videos sometimes is really helpful, as well as pamphlets and brochures and yourself being able to talk about it. So sometimes you hear the word hospice and palliative care, and sometimes you see them put together, hospice palliative care, like the Champlain Hospice Palliative Care Program. We put those words together because in Canada, we see them as equal. They mean the same thing, hospice palliative care, HPC. But there are hospices. Those are places, institutions where people actually die. And so it's confusing sometimes when people hear the word hospice care or palliative care, and helping people understand that in Canada, it is all the same. And both in a hospice and in a hospital or in a retirement residence, we can receive a hospice palliative care approach to care. It means meeting the needs of people who are living with serious illnesses and improving that quality of life. That's a palliative approach. So it's kind of the larger umbrella. And then end of life, we certainly have a palliative approach at end of life. And I know Deb's going to talk more about that next week, but it's specifically meeting the needs of those who are irreversibly dying. Sometimes we call it actively dying. Or it could be even talked about as a terminal phase. So with a PPS, a palliative performance scale of close to 20 or 10, those people are actively dying. They're usually in bed, they're not eating very much. They might be coming in and out of somnolence or even a coma. They're usually very lethargic, and they're very, very close. And that is typically what many people think when they hear the word a palliative approach. We think of end-of-life care, but palliative care approach can be offered much sooner than that. So here at the Champlain Hospice Palliative Care Program, we've divided our mission to tell people about what hospice palliative care is by using these 5 components. And I'm just going to work through them. And if you want to have a chat about them when we're done, we can certainly do that. And I'm going to talk about quality of life, holistic care, patient-centered care, a team approach, and the concept of chatting about this earlier and attending to things earlier is better than later. So here we go. So palliative care approach is focusing on the quality of life. And quality of life is all of who you are. It's what makes you feel well, what makes you feel whole, what gives you meaning and purpose, and all of those experiences. So most people, when they hear that we're offering a palliative approach, let's say in long-term care, people think, oh, well, is my mother dying? And it's like, no. Your mother is coming here because she needs a little more support, and we're focusing on a quality of life, and our approach is about quality. So quality of life, most people say, oh, I'd like my mom to have quality of life, or I personally would like to have better quality of life, and I would like to find more meaning in my life as I live with a life-threatening illness and as I move into failing with whatever I am living with, even just aging. Dr. Balfour Mount is kind of the founder of hospice palliative care in Canada, because he studied years ago with Dr. Cicely Saunders in England. And this is one of his quotes. And he said, "What surprised me is how little palliative care has to do with death." What surprised me, and he was a surgeon at the time, he says, the death part is, for him, almost irrelevant. Our focus, he says, isn't necessarily on dying. Our focus is on the quality of life. the quality of living until death. And I have worked with Dr. Balford Mount over the years, and he and other physicians have told me that the more they focus on quality of living in this experience of having a life-limiting illness, enhances that quality of people's existence by managing their symptoms and caring for them. And they started to focus much more on the person and their dignity and who they were, not necessarily the dying, although dying is a huge part of palliative care. Suffering also is a big part of palliative care. And this is a definition that the Canadian Hospice Palliative Care Association has put together with regards to what is suffering, because they said we're trying to relieve or to address suffering. So it's a state of distress associated with an event that threatens the intactness of that person, that whole person, and is accompanied by a perceived lack of options for coping. So one experience for one person, they might tell you that this is not suffering, and another person on the outside looks like they're having the same experience, and they might tell you, I am definitely suffering. My suffering is different than Debbie's suffering, even if we have on the outside the same life experience. And also it accompanies this idea that we don't have any options. So their palliative care offers them this approach to have more options for what is bothering them from a holistic perspective, body, mind, and soul. Body, mind, and soul, it's holistic. Palliative care attends to the whole person, not just the body, but to the mind and the spirituality of people, because we are all connected. And there's an interplay between the body and the mind and the soul throughout our entire life. We're working on this balance, but as an illness takes over our life and we move closer towards frailty and dying, this balance is very fragile. And palliative approach of care helps us address not just body, but how the mind is a part of how it affects the body, and the soul, how the soul affects the body. I remember years ago caring for a gentleman that was very, very close to death. And I was working for the VON at the time. He was in his home, and I was sitting by his bedside, and I was just kind of checking in to see how he was doing. I just arrived into the home, and I can't remember his name. I'll call him George. I said, George, how are you doing? And I just looked right in his eyes, and he said, oh, Ruth, he says, I'm composting. I said, George, you're composting? And he'd been a farmer from up the valley, and he was like, yeah. And he was very close to death. And I said, George, you're composting. That's an interesting concept. And then he lifted his head up off the pillow as much as he could muster, and his eyes got really big, and he says, but Ruth, don't kid yourself. My soul, vibrantly alive. And he had this sense that his soul was still quite active and vibrant within his being, but his body was failing. And he had enough wherewithal to actually talk about that and share that with us. So a palliative approach is addressing not just the body, but the interplay and that delicate balance between body, mind, and soul. The Canadian Hospice Palliative Care Association has created the square of care you might be familiar with, and in that are the domains of care. And in the domains of care, there are these areas that tell us we're a whole person. We're not just managing disease. We're not just doing something physical. We're not just doing psychological or social issues. We're tending to the spirit. We're doing practical things. Deb and I worked in a hospice for years, and we had a lot of volunteers to do a lot of practical things. And that's a part of quality of your existence, those ADLs and all those practical things, and loss and grief. We're experiencing loss and grief, both the patient and the family. The center of this model is patient and family. And then that one at the bottom left-hand corner is end of life care. So there's the death. So here is this domains of illness and palliative care approach. And one little corner is really dedicated to end of life care. And that is those specific things that when people are closer to death, that they want attended to from a holistic perspective. I love these domains. I love to look at people from these domains and to see people as whole entities. There's a huge movement in the hospice palliative care to help us talk about hospice palliative care earlier than later. At the onset, at the diagnosis of someone of a life-altering illness, a palliative approach can really help, and you were talking about helping and supporting earlier, to manage symptoms that are happening within their bodies, to explore advanced care planning so that they can tell us what is meaningful for them and what gives them purpose, so that we can help with conversations of care and goals of care and have those conversations and know what people want. So the earlier we have these discussions, the better. I got married years ago and I had a great wedding. And the evening of our wedding, after it was all over, my husband and I, his name is Grant, it was about 2 a.m. and I said, Grant, let's talk about dying. He said, Ruth, we're 25 years old. I said, I know, honey, but we just made a commitment till death do us depart. And so let's talk about this earlier than later. We're 25, hopefully we'll live for a long time, but let's talk about advanced care planning. Let's talk about what's meaningful for us and what's important for each other, because now we're going to take care of each other for the rest of our lives and have those meaningful conversations. And the earlier we have those conversations. Here's a little video that explains this very well and looks at this concept of earlier over later.
What comes to your mind when you hear or see the word palliative? Many people, appropriately, think of words such as compassion, dignity, or quality of life. However, for many people, what comes immediately to mind are the words dying, terminal, and end of life. Unfortunately, too few people think of palliative care alongside treatments to control the disease.
I'm Dr. Gordon Giddings. I'm a palliative physician at the University of Ottawa and clinical content editor of Pallium Canada. The aim of this Pallium Doodle is to explain that palliative care is not something for just the last days or weeks of life, but should be initiated much earlier.
To better understand this, let's look at the illness trajectory, starting at the time of diagnosis of a life-threatening illness. In some cases, the disease, whether it be cancer or another non-cancer disease, can be cured with treatments. In other cases, however, the disease may be incurable. Let's draw a graph around this journey. On the x-axis is the length of that journey from diagnosis to death. On the y-axis is the goals of care, the treatment and care options in focus. Now, unfortunately, because people often think of palliative care only for the last days or weeks of life, they will only activate a palliative care approach in the last days or weeks of life. Let's look at the negative consequences of this. They include lack of symptom control with unnecessary suffering, inappropriate treatment choices, prolonged psychological distress because no one is addressing the fears and concerns of the patient, lack of discussions about prognosis, or lack of preparation regarding care choices and treatment goals. So what do we need to do? Well, we need to erase the old model of palliative care and use a different model, a different approach. What if we start palliating early in the illness? This does not mean that treatments to control or cure the disease and palliation and supportive care are mutually exclusive. The model of early palliative care is much more patient-centered and responsive to patient needs. Is there evidence to show that early palliative care is better than late palliative care? In a large US-based study by Timmel and colleagues, the model of early palliative care was compared to the usual or common model of palliative care, only in the late phase of disease. What do you think the results were? Which group do you think did better? Which group had less depression and less anxiety? Which group had better quality of life and symptom control throughout their illness? Which group do you think lived longer?
Those are the questions. Which group had less depression and less anxiety? Talking about palliative care earlier does not bring about anxiety. Talking about palliative care with the understanding of it offering us quality of life and addressing symptom management and maybe answering some of our existential distress probably reduces our anxiety. And so the opportunity to talk about it earlier, when people move into long-term care residence or ends up moving into retirement, it's a time where you're changing your environment. Anytime you're having that shift and change is a good time to kind of talk about and look at concepts about quality of life and what's important for us at this age and stage. And looking at quality of life, of course, the group that talked about it earlier are addressing those issues. And this study, which was kind of interesting, asked how many people live longer. And they did find that people lived a little longer. And sometimes I find that when people receive a palliative approach, whether they're in their home or whether they're in a hospice, all of a sudden their anxiety is lessened. Their burden to their family is a little lessened. All their symptoms are being really addressed and they're being seen as a whole person. And there's such a lift for people to have that type of approach of care that sometimes they feel like they're improving. And I've even had people say, maybe we brought them to the hospice too early. I'm like, no, it's just that they're having a great approach of care and they're less anxiety. And so they're sleeping better and they're not being so restless. And you as a family member are feeling more comfortable as well. So possibly in this study, these people actually, with their quality of life enhanced, they live longer. That's not the intent of a palliative approach, but a palliative approach has this intent to live to our fullest capacity with some sense of dignity. And that obviously in this study said that people lived a little longer.
The early palliative care group experienced significantly less depression and anxiety, better quality of life, better symptom control, and astoundingly, they lived almost 3 months longer than those patients who received only late palliative care. So the key message is palliative care early is better than palliative care late.
So those are the two models there. And I think there are still many people in society that only see it as the old model, that when we talk about palliative care, it's somebody's actively dying and it's end of life. And that's a great approach for people at end of life. But we're really trying to help people see, and as a palliative clinicians, we'd like to see people earlier in that trajectory to be able to help with anxiety and different symptoms, and recognizing that they're also might be having modifying treatments. They might still be having chemo. They might be going for radiation, that we can do both. I like this little picture that we can walk through both doors at the same time. It's not either or. You receive a curative approach to care, and then all of a sudden you end up only receiving a palliative approach. But you can have a palliative approach with issues that addresses those needs. And you can also have a curative approach. So if I have a urinary tract infection at the end of my life, I would definitely like a curative approach with some antibiotics. But I'm also wanting to receive a fair bit of a palliative approach for other symptoms that are happening within my existence that I can't cure, or I'd like at least modified or managed really well to give me some sense of quality. So this model, and in my career, I have seen that it was two doors, and literally people would say, when this door is shut, this other door is opened. And now we're living in a society that both doors are open for you, depending upon what the needs you have. So you can receive a little bit of palliative care, and a lot of the medical model can still be there for you. We can cure sometimes, we can relieve often, but we can always comfort. And a lot of you felt that that's what hospice palliative care, that approach was comfort. And comfort is a big part of that in the existence of trying to relieve and sometimes trying to cure with regards to what is ailing people. The fourth factor that we're trying to stress is that it takes a team, it takes a family. They say it takes a village. And certainly in the region, we are a village. I see Debbie there working in her capacity with regards to community support. Genevieve is there with regards to a consulting team for the region. There's so many resources in the region to help people. And we need a wide variety of people managing this, not just call the chaplain, call the nurse, call the whatever, but it reaches out that all of us have a part to play. So whatever role that you have where you work right now and you're sitting there going, well, that's not really my job, I'd like to encourage you to think that it probably is. You have a role to play within your scope of practice, within your profession, to do some palliation throughout the day with the residents and the care providers that you have, and to recognize that more so that you can start to offer a palliative approach early to bring about the best quality of care for the person that you're working with. I don't know how many people have read this book. I'm kind of enamored with this group. I've just finished reading it. Hope for the best and plan for the rest. And it's a researcher and a palliative physician in town in Ontario, I guess they are. And what I loved about it is they're trying to incorporate the patient as a part of the team. They're trying to help the patient and the family navigate this system, and recognizing that there is a big team out there, and sometimes it's very complicated and it's confusing, and sometimes they're not necessarily always connecting well together. And he's saying, you know what? Let's also incorporate the patient and their family as an active member in this team. And he has 7 keys to navigate life-changing diagnosis. And it's a nice read, and it's an easy read. And he walks you through some of the assumptions that patients have about the system, and then he kind of debunks them. And then he gives you some great exercises on how to be more active within the system. Because he said, you know, I might not be able to change the system, but if I can work with patients and families to work the system, to learn how to play the game, they might be a part of the team. So this little book is a great book to incorporate people into the team, not just having a team do things to them, but to have them see themselves as active. It's easy to read. I encourage you, if you're working with family members who are maybe a little frustrated with the transition that they're moving through and all the different names and voices that come at them. I see Debbie's face. She's put herself on video there, and I smile because I know she works with team all the time, but it's quite complicated at times. There's a lot of partners coming and going, and this book can really help facilitate that confusion and empower residents, patients, people that you're working with to be an active member of this team. It is delivered by teams, but it's delivered with you as a part of the team. And it's person-centered. It's person-centered. It's not disease-centered. So person-centered means that we align with people's values, their wishes, their beliefs. How do we do that? We get to know them. We listen to them. We ask questions about what's important to them, what makes them feel like a person, what matters to them, and recognizing that each person is unique and getting to know people. People are not labels. People are not all these things that we label them as. And when we're working and our lives are complicated, we start creating forms and policies, and we start to label. We label people as a way of kind of categorizing them and managing money sometimes as well, and putting people into slots. But people are unique. And this care is about person-centered decision-making. When we do advanced care planning and goals of care and looking at consent, it's each individual person. So palliative approach is about attending to that person. So it does mean taking time to get to know that person and to listen to that person and to ask those questions of that person. What is important to them? What's important to them as they make decisions throughout their life, living where they're living and moving into other living environments. It's all centered around who they are as a person. Dr. Larry Liebrack was a physician at Mount Sinai Hospice, a palliative care hospital, and he was a lovely physician for years. And I'm just tipping down my computer so I can read it. And he said, healing, that is something different than curing. Healing is to make a person whole, a whole person, a body, mind, and a soul. And to relieve, that's so adventurous to try to relieve suffering, but at least to attend to suffering and to give that individual a sense of who they are as a person. So they don't think lost in the system as just a patient or a label or a number. Palliative care is person-centered, he says. It's not disease-centered. And we have lots of systems that are disease-centered and they work really well for us. But a palliative approach is person-centered. It's very individual in its approach to care. So those are the 5 things that the Champlain Hospice Palliative Care program is kind of filtered out of that definition. We want to focus on quality of life, whatever that looks like. We want to be holistic, means body, mind, and soul. So that needs a team approach. We want to talk about this earlier than just at end of life. Yes, at end of life, for sure. That's really important, but much earlier. And we're person-centered. We're all about the person-focused. And when you look at those 5 factors and you talk to people about offering a palliative approach in whatever capacity that you work in, if we approach it from those 5 domains, I have very few people say to me, oh, that's not something I want. I don't want that. I don't want quality, and I don't want you to treat me like a whole person. I don't want a whole team working for me. So sometimes bringing a palliative approach earlier than at just at end of life, we can move that away from just being at end of life, which definitely is. And I know, Deb, you're going to offer us a lot on that in the coming months, but it's earlier than that. Recognizing that we're all trying to navigate this life-threatening illness, whatever that may be. And it might be elderly frailty, just aging, and recognizing that as the years go by, I have less years ahead of me than I have behind me. And a palliative approach might be very helpful for you. No, you're not actively dying. I tell Deb this all the time. Deb, I'm picking on you because your face is right in front of me. But my husband, I palliate my husband every day. Since the moment I started dating him, I focused on his quality. I saw him as a whole person. I attended to his suffering. I tried to help manage and modify things in his life that brought about some respect and some quality and some dignity. But was he actively dying when I met him at 25? No. And is he actively dying right now at the age of 64? No. Am I palliating him today? Yeah. I palliate him every day in some way that meets his needs, because I can't fix things and I can't cure things. So the benefits of palliative care are holistic in nature, and it addresses everybody. It's not just for the person that you're serving, the resident, the patient, the person, but it's also, there's a benefit for us as caregivers. It puts us in a very compassionate state. It enables us to have empathy and compassion, which can further us along to not feel burnt out. It gives us a sense of well-being to be a part of people's lives in that way. And it also helps the whole system to have a palliative approach. Little quote from Cicely Saunders: how people die remains a memory on those who live on. So that palliative approach helps people in times of grief as well, that they had that support. This is a picture of me and my mom. This was during COVID, and I got to sneak her outside. She lives in a long-term care home. And we had a moment where I took down my mask and we had a smile. Palliative care is a philosophy. It's an approach of care. People aren't palliative, but the care that they can benefit from is palliative. How do we offer palliative care? We can have it in their home, and the home is retirement home, long-term care home. It can be offered in a hospital with a team. When you're going for acute symptoms, issues, it could be in a hospice, which is like a residence where people can die. Really, palliative care can be offered anywhere where people are willing to stay and live and try to find some dignity in the experience that they're having, and that community come to them and support them, whether it's their family or their friends, or whether it's paid professionals like Debbie and the consulting team and nurses within the environment. Palliative care can be offered everywhere and almost anywhere, which is kind of exciting. So my question for you as we come to the end of our hour is, how often now, and I think you know what a palliative care approach is. I feel like I zinged through that because I think you could have given this speech. You could have given this little lecture. How often do you offer a palliative approach to somebody in your life or in your care? And just to start to see a palliative approach, that action more widely in your scope of practice and in what you do every day. Only when someone is actively dying, only when someone's in pain, maybe once a week I can see myself. Yeah, Maybe I'm doing it once a day. Maybe I'm doing it 10 times a day. Or I'm doing it so many times every day I can't count. I was thinking with Carl, you see Carl's face, he's just come on. He's a colleague of mine with the Hospice Palliative Care program here in the Champlain. And Carl palliates me every day. He has such knowledge and technology that I don't have. And when I have to do something like this, he sets it up and he gets you in and out of the doors and he listens to the chat and he's palliating my distress about, oh, Carl, can I do this? I don't understand this. And Carl's there just to palliate my anxiety. And I so appreciate that, Carl. So Carl probably palliates people at least 10 times a day in his life. It doesn't have to be just at end of life. So there they are on the dock. Soon we'll be back to that in the spring. Someday we're all going to die, Snoopy. Snoopy says, yeah, that's true. Absolutely. We're all going to die. But all the other days, we will not. And a palliative approach is for both. It's for all the days that we are not actively dying and needs are being asked to be met. And a palliative approach would be wonderful for that. And absolutely, at end of life, and when people are very close to death, a palliative approach is absolutely 100% there for them. So here's some of your challenges I've put forward together for you. You probably can come up with a few more after we're done, but consider these 4 things. Consider a hospice palliative approach integrated with the care that we provide for people with chronic and life-changing illnesses. So start looking at the population that you're serving a little bit differently and offering a palliative approach to those people. Offering a hospice palliative care approach to people based on need rather than on prognosis. On need. Do they have a need that fits into those 5 pieces of care? And could I offer a palliative approach based on need as that person presents it? Which means I need to listen to them and ask them those questions. Consider a time when hospice palliative care walks hand in hand with other modifying diseases and treatments. So not waiting until the end. Consider offering a palliative approach much earlier. And consider ways to open doors to talk about death and a place of living and dying and having those discussions and being able to talk about them earlier than later. So I'm just challenging you with those 4 little concepts. I think you know what hospice palliative care is, so I'm just asking you to see in your daily lives and wherever you are working to be a little more challenged. I'm at the end of my talk, but for you, you're just beginning the next thing in your life. And I'm open to any questions and discussions at this point.
There's a couple in the chat we can go with here first, Ruth, and then I think we'll stop the recording if anyone wants to ask some questions too with their video and audio on.
Sure.
So one of the questions here was, or actually it was more of a comment maybe than a question, but they're talking about how as a team, they'd like to explore options to better support retirement homes in the context of engaging a physician or other clinical support, and how that's, this is particular in retirement homes where there's no in-house clinician. And another person mentioned how when they're visiting with patients, they always ask about their goals and what's most important to them as they age.
Absolutely. The first question, Carl, back to working in retirement homes. I see Genevieve's face has come back up for me on the screen. And she works with a team that definitely would be working into retirement homes. Genevieve, can you respond to that with regards to the work that you could offer in retirement homes?
Yeah, like I can try. Lillian, if it's okay, maybe either in the chat or in as like you can talk as well. Better options to support retirement homes in the context of engaging a physician. So are you a care coordinators? Because I know we have care coordinators on the line, or do you work in a retirement home?
Can you hear me?
Yes.
Okay. I'm a care coordinator, and within some of the retirement homes I support, there's no in-house physician. So at times when we've explored options or you've initiated a discussion, for example, on how best to support, the biggest challenge becomes that clinical piece. And with the understanding that it's a huge challenge across the board. So that's why I brought it up to explore options in the context of retirement homes. And at times, for example, even when a retirement home has a physician, they may not always be available, or there are times there are gaps in that. So which would be a way as a team to explore the best supports? For example, maybe sometimes towards the end of life and there's no immediate access, for example, for the symptom management kit, for the clinical orders, or nursing is in place, but then exploring those pieces of engaging a clinician with mind that there are many challenges in that, and there's the context of policies, there's a context of labels, as you mentioned, there's a context of finances. So all those pieces, just bringing it to the table to explore a way forward.
Yeah, so I mean, we probably don't have enough time in the world to really sort this out today, but I guess, you know, as much as, of course, as Ruth said, like palliative care is a very interdisciplinary discipline, like without, you know, a physician and a prescriber, unless there's absolutely no symptom issues, it is hard to provide palliative and end-of-life care in a retirement home or any care setting. So they tend to be kind of essential to the bigger picture. I mean, once in a while we run into patients who die very peacefully and don't need a whole lot of symptom management, but as a general rule. So, and at the same time, we are starting to hear that more retirement homes don't seem to have a physician, which is very concerning and kind of unheard of, right? Like up until a few months ago, I don't think this is something we were hearing a whole lot. So yeah, I saw Caroline here, you know, depending on where you are in the region, because just as a reminder, this session was offered to all retirement homes in the Champlain area. So in Ottawa and other pockets of places in Champlain, we do have palliative care physicians who can take over the care and become, you know, primary care physicians for palliative patients. So that's always an option. If there is a physician in place in the retirement home, like we know sometimes they're not easily accessible, but that being said, this is mainly the role of our team, right? Like the regional palliative consult team or our PCT. You know, we're often kind of that bridge or that link or that support for the retirement homes, for the visit nurses, and for family physicians. In terms of, you know, sometimes accessibility. So, you know, we have a way to reach them 24/7 when it's needed, as opposed to people just trying to reach their clinic and talk to them. So we can facilitate some of these connections if they are physicians. We can't force anyone to do palliative care, but at the same time, you know, there is a responsibility and an accountability for physicians that when they have patients, especially in retirement home and for sure in long-term care homes where they have a responsibility to continue providing care. You know, sometimes we may know, depending on what area you are, we may know of other physicians who may be willing to take kind of what we call orphan patient on, which means in our language that they don't have a family physician. So never hesitate to reach out to our team, because I always say this, like we keep a roster of family physicians we work with, and I think we have like over like 1,000 names, if not more, on that roster. And for a lot of them, we have their cell phone numbers. So if you're ever unsure or you're not successful at reaching a family physician, just, you know, give us a call for sure. But yeah, like for those retirement homes where there's absolutely no family physicians, it can be very tricky, and it may be a barrier to being able to provide end-of-life care in that setting. So I think this is also something, important for families to, and patients, if they're able to kind of understand and make certain decisions. But I think it's very important for them to understand that, you know, it may not work out to provide end of life care in the home if we have no access to a physician or to medications. And then we may need to plan a little bit ahead of time as to say, okay, like, could a family member take this patient home if it's just in the last final weeks, for example? Like, we know that's been done before. Or do we need to look at hospice or the palliative care unit at St. Vincent's for the kind of more end of life period?
Yeah. Deb, do you have anything else to say about that too? Because I'm sure you're involved with the retirement homes.
Thanks, Ruth. It's one of the initiatives that we've identified where we feel there's opportunity for improvement to help identify those residents who could benefit from it, help those family members who also could benefit from it. So it's, I think, better understanding what the palliative care is, what the merits are of it, identifying those patients who could benefit, and really marketing that. So, you know, advocating with the DOC or with the director of wellness, with the physician, to say, you know, I'm concerned about this patient. I feel that they could benefit from this approach, and just doing that advocacy that way.
Yeah. I agree with the advocacy. I think we know in our minds, obviously, what a palliative care approach is, but then identifying with every resident or patient that we see, could this approach be helpful? And then having that discussion. Monique says that I have these discussions with regards to goals and what's important to them as they age. And I think just being able to have those discussions more with people, help people have a sense of a palliative approach could really help us here and help us there without being frightened about us talking about end of life. Yeah. Can't say it enough. Earlier is better than later.